This is Crystal Fenn with MedPage Today here in San Francisco at the ASCO Genitourinary Cancer Symposium, where researchers have reported that treatment-induced hypertension may be a marker that targeted therapy is working in kidney cancer. I spoke with Dr. Brian Renal of the Cleveland Clinic, who presented results on sunitinib.
So what we found is that patients with metastatic kidney cancer taking sunitinib from the analysis of 3 pooled prospective trials who had treatment-induced elevations of blood pressure, which we defined as systolic pressure over 140 or a diastolic pressure over 90, had better clinical outcomes than patients who didn't have treatment-induced hypertension. And the clinical outcomes were objective response, progression-free, and overall survival. It's hard to know what the immediate clinical implications are. As I think people have been doing, they need to manage hypertension even before they start the drug, and certainly on the drug. It shouldn't be a reason to stop the drug in general, assuming that it can be managed, which most often it can. Because it's a post-treatment biomarker, we can't use it to select patients before treatment. It's really at this point an association of a treatment-induced side effect and outcome. I think if we understand the biology of why it happens, then we can maybe select patients. But it's really just an observation at this point, and absolutely patients need their blood pressure managed.
Renal also explained that the link makes biological sense.
Sunitinib is a VEGF receptor inhibitor, and VEGF is implicated in vascular biology, speaking generally, certainly with the development of blood pressure. So in general, for VEGF targeting agents, the development of hypertension is considered to be an on-target effect. That is an effect of blocking the receptor or blocking the ligand itself. I don't know if the exact mechanism is known. We know that VEGF depletion reduces nitric oxide synthase, so it reduces a potent vasodilator and causes vasoconstriction. It also probably, sunitinib and others probably also kill endothelial cells, blood vessel cells, so you get apoptosis of small blood vessels. So you get more what's called rarefaction, you get more tightening of the existing vasculature. So there are mechanisms out there. I don't know that there's one that's necessarily decided to be the predominant one.
So while clinicians need to manage hypertension induced by the drug in kidney cancer, this side effect may be a positive for patients. Here in San Francisco at the ASCO GU meeting, I'm Crystal Fenn, MedPage Today.